So we're going to switch the order of the talk a little bit, and we'll have Dr. Sean Cleary talk about surgical management of polycystic liver disease. Dr. Cleary, it's actually a really a pleasure for me to meet you since we work in the same hospital. He was recruited from the Mayo Clinic and is a very experienced hepatobiliary surgeon who had done a lot of work in polycystic liver disease, and welcome.
All right. Okay. Thank you so much, Dr. Pate. It really is it's an honor and a pleasure to be involved today in such a very passionate and focused meeting. It really is a pleasure. So I have at all these meetings we're supposed to declare our disclosures and relationships and things like that. So I have some relationships with companies that, given that I'm a surgeon, aren't very relevant in this disease. But I do have a disclosure that I learned almost everything I know about polycystic liver disease from this man here, David Nagorny and Dr. Torres. As Dr. Pei indicated, I did my residency training and fellowship at the University of Toronto in liver surgery and liver transplant surgery. I learned very little about polycystic liver disease, and I had the opportunity to go and become the chair of hepatobiliary and pancreatic surgery at the Mayo Clinic, and I was there for 7.5 years. And for 6 years, I had the honor of working with this gentleman, David Nagorny, who I think with Dr. Torres and Dr. Marie Hogan and others who I'm going to quote extensively, I learned a lot about polycystic liver disease because it's one of those things where you don't know what you don't know until you find it out. And so this is my disclosure in that most of this work, again, has been done by Dr. Torres and Dr. Nagorny, who was extremely patient teaching me. So I thought I'd start with a case presentation. I don't know if this will, oh yeah, there we go. So this is actually a patient I saw recently. I think this is a type of scenario that is very familiar to all of you. Obviously, you all recognize that this is polycystic liver disease. This is a woman who had been here in Toronto, had been managed for a long time. She had significant symptoms. She couldn't participate in certain activities with her children. She certainly stopped participating in sports many years ago and any sort of activity. She really had problems eating because of the effect on her stomach, and was starting to lose weight. And again, weight changes can be very difficult to interpret, but she really felt that she was losing lean muscle mass and she just wasn't able to eat enough. And again, she was extremely frustrated over years of really not being able to do this. So again, I think this has probably been extensively explained and we don't need to do this to a great extent, but really the symptoms that we see, and again, we want to sort of diagnose are the mass effect and the actual space occupying aspect of the liver and the cystic disease. It has implications on the stomach in terms of our ability to eat. It has, for certain patients, it has significant pressure on their diaphragm, which can limit their respiratory reserve and their ability to take deep breaths or even exercise because of their inability to adequately expand their lungs. You can see this patient, in the top right corner, their diaphragm is well above where it should be. We can get elements of biliary obstruction and not so much from the fact that the cysts arise from the biliary epithelium, as everybody knows, but actually the mass effect itself can start to occlude these. So these patients can look quite unwell. And I think, we know that these patients can have acute episodes of growth associated with intracystic hemorrhage, but really for most patients with polycystic liver disease, that's that progressive growth over a number of years. And in many places, again, people, when they're seeing physicians and nurses and other healthcare professionals that are not in this room, they're kind of told that they just have to put up with it. And it's sort of like being, I say to my trainees, it's like being 9 months pregnant all the time. And so again, we deal with a lot of cysts, and again, this is not the true polycystic disease, but a lot of the things that we learned from simple cystic disease, we started to apply to polycystic disease. But really, in terms of how we approach these patients, it really is quite different, and that's why I think conferences like this are so incredible, because there really is an underappreciation and an misunderstanding of this disease in total. And so obviously, I think we've gone through a lot of the treatment options. There are medical management options that Dr. Torres will talk about. There are aspiration with sclerosis, which my friend and colleague Dr. Shlomowitz will talk about. But really, our surgical options are around fenestration, which is opening up the cyst and allowing the fluid to drain into the abdominal cavity and resecting as much of the cyst wall as possible. And resection, which is actually removing large components of the liver from patients. And to be honest with you now, almost everything I'm going to talk about is going to be a combination of resection and fenestration, because you can't really do one without the other. You can't really do resection without fenestration. You can do fenestration, but I think this is what kind of has stifled a lot of the surgical management of polycystic liver disease, is that people kind of took out the cysts around the edges and didn't really were afraid to or didn't want to get into more aggressive operations. And I think what Dr. Torres and Dr. Nagorny have shown over the years is that actually being appropriately and selectively aggressive with surgical management is probably yields a long-term benefit. And I'm hoping over the next little while I'll show some of the data, and hopefully going before Dr. Torres doesn't steal much of his information. So again, aspiration is not really a diagnosis, and Dr. Shlomowitz will talk about it. Aspiration and sclerosis, but I really sort of try and look at the whole liver and the whole patient in terms of what is happening. Obviously, there are a few classification systems out there. This is the one by KDIGO. So I don't find it as applicable just because it's a rather descriptive classification, I find, and it really doesn't help guide us in our management. And again, the reason why I declare these disclosures is that I certainly prefer the Schnelldorfer or the Mayo classification, which is certainly what I was indoctrinated with, that divides it up into, instead of KDIGO, which was 3 types, into 4 types. And not only does it describe the involvement of the liver disease, but also helps guide the management. So there's A, B, C, and D in terms of the extent of symptoms, the number of cysts, and then again, getting into actually what's more clinically relevant is how much normal liver is left behind. How is the blood supply in and out of the liver? And then again, when you take all of those 3-4 factors together, you can start to sort of guide patients towards certain management. And again, this just sort of pictorially describes it in terms of A would be sort of limited number of cysts without significant symptoms. And again, we generally manage these expectantly. B would be multiple cysts on one side of the liver. And again, these are things where things like fenestration can be very useful, or fenestration with resection. Occasionally, there'll be patients where sclerotherapy are going to be appropriate. But then I think what we all know is sort of the really difficult cases of polycystic disease are the type C disease, where we have dominant disease on one side of the liver, yet still some areas of preserved parenchyma. And you can see, for those of you who aren't liver surgeons or radiologists or nephrologists, this light gray area, this light gray area at the back here, this is the normal liver that I'm always looking for. This is kind of the parts that aren't involved in cysts. And so you can see in this patient here, they've got a few cysts, lots of relatively normal parenchyma, particularly on the right-hand side of the liver. Here we've got a patient where seeing the normal liver is a little bit more difficult because it's sort of interdigitates between the cysts. So this is certainly a lot more complicated. And then obviously we all know patients where their liver look like this, where there's very little, if any, identifiable parenchyma. Here you can just see some tiny islands and projections of normal liver, that the liver's really been replaced by cysts. And this is, from a surgical perspective, extremely challenging to deal with. There are patients that can get surgery with this type of involvement, but certainly these types of livers are the type where we start to see the actual function of the liver declining, and we want to consider things like transplantation. It is amazing to think that these patients like this can still have relatively normal liver function. They've got enough functioning kind of liver cells and blood supply going in and out of that liver to function. But certainly as the disease progresses, we can actually see compromise in the liver function. And once we see impaired liver function, that really is when we start to look at liver transplantation. So for most part, we'll be really talking about the B and C disease that gets involved. And again, this is sort of looks at really sort of not only the types of disease, but again, it helps guide us in our management. And again, you've got me to talk about one side, Dr. Shlomovitz to talk about sclerotherapy, and then obviously medical management and observation, which will be, so Dr. Pei has arranged a full coverage of all of the topics and relevant topics involved. So this is just a quick thing of what a fenestration looks like. This is actually a robotic procedure. So this is really where you make a small hole in the cyst and you can decompress it. This is really someone with Schnelldorfer B. So they've got fairly, a few large cysts that were particularly symptomatic. This one, although we didn't show it at the very beginning when it was really big, was compressing on her stomach and really causing her symptoms, particularly when she ate. What we do then is we sort of want to excise as much of the wall as possible to create an open drainage pathway for a lot of the fluid. This is actually, and I apologize because I usually sort of present this video to surgeons. This is actually a robot that helps us do operations. It's called the Da Vinci XI. And what this does is just sort of what we're trying to do here, or what I'm trying to do, is remove as much of the cyst wall while not removing any of the parenchyma. What you can see here is that this cyst will open up nicely. We'll remove a lot of the wall. And then what will happen is the fluid created by the remaining cyst wall will just be reabsorbed by the abdominal cavity. Most patients with these kind of cysts, particularly Schnelldorfer B, will generally tolerate this quite well. Some of the really large cysts, so when they're sort of 20 centimeters in size, they can start to experience some fluid shifts because of the large amount of fluid created by the lining of the cyst, which is what sort of creates the fluid inside the cyst. The rest of us is just kind of, I'm happy to show the rest of the video later if anybody's really interested in that. So how do we, so what is for us fenestration really good for? Well, it's really good for exophytic lesions, so things that are on the surface of the liver. It allows you, again, you can see how in this cyst you'd be able to come along and resect much of this cyst wall here and really not have to get into the liver parenchyma. So leaving this patient with as much of the parenchyma as possible, but then you've still left them with this part of the wall of the cyst that's still going to create some fluid. Those cysts, when we do fenestrations, those cysts invariably, and I tell patients, always recur. The cyst doesn't go away completely, because what's going to happen is there's going to be other structures in the abdomen, like fat within the omentum, or sometimes the stomach, or sometimes the diaphragm, that's going to fall over top of that cyst. That will kind of recreate the cavity and allow the fluid to reaccumulate. But the cysts always come back much smaller than they were originally, and that's where the symptomatic benefit is from that. And so I always tell patients, I'm not going to take your cyst away. It's still going to be there, but it's going to be significantly smaller. All right. So getting into the more depths of resective techniques. So this again is the experience. This is the first paper in the modern era that Dr. Torres and Dr. Nagorny published from Mayo Clinic in Rochester. Chuck Rosen is a transplant surgeon, and Thomas Schnelldorfer was one of the fellows there. They described 114 patients. Now, all of these patients had polycystic liver disease that was affecting their life. So the ECOG performance status is really kind of impacts a measurement of how much their liver disease was impacting their life. And 1 to 3 is actually quite a significant range. So one is up to spending up to 25% of the day in bed or on the couch or because of the disease. 3 is spending almost 75% of the day. So these were people were a broad range and were actually quite sick. They had severe vascular compression, about 65%. And again, they were very aggressive. I think this is what Dr. Torres and Dr. Nagorny were unique in that they were very aggressive with resecting the liver parenchyma and fenestrating as much of the cysts. And what they showed was that people improved significantly in terms of their functional status. Only of the 141 patients, about 13 patients needed a second operation or second intervention, whether that was sclerotherapy, another resection, or even transplantation. And the median time that they got of those 13 out of 141 patients that needed reintervention, they lasted 6 or 7 years before they needed reintervention, and they were able to do it reasonably safely. So for liver disease, operative mortality means being alive, not people who are not alive 90 days after the operation. So 4% for an operation this size is very similar to what we would do for cancer or for other indications. And so this really kind of showed that these graphs really showed kind of two things. One was that this patient population did very well considering compared to cancer patients or any other patients with similar performance status. When you looked at but it also showed that patients with polycystic liver disease, this is a real disease, and they died from complications of their cystic disease. They died of other problems related to it. So that's why Dr. Torres and Nagorny looked at disease-specific survival, which is survival associated with when they have outcomes related to their polycystic liver disease, and then compared them to the general population. So this is a major impact. It's not just something to kind of put up with. And again, shows the benefit of really fenestration and hepatectomy in terms of these patients being actually able to probably live longer than they could without it. Here, transplant, I think, was used very, very selectively. And so those patients were quite sick by the time they got to transplantation. You see some of them didn't survive the initial period after transplantation. They then followed this up later when they looked at, now they've done another 40 further patients. So there's 186 patients. Again, these were very aggressive resections. The median number of segments of the liver, so the liver is made up of 8 segments that they had removed, was 4. And so that's really removing almost half of these patients' functioning liver. The operations, just with every other liver operation, got a little bit safer over that time. So mortality dropped to 2.7%, and only 2.6% of those patients developed liver problems after the operation that ended up needing transplantation. So they were able, Dr. Torres and Dr. Nagorny were able to show not only the sort of the 5-year trend for these patients, but go out to 25 or 30 years, really showing that patients continue to do very well, but also show that the significant drop in the size of patients' liver that they were able to achieve with these operations. And then the question was, were these benefits durable? So really this kind of summarizes it in that this the curve here, this first one is kind of the change in liver volume from immediately before surgery to just after surgery. And these are patients who then were followed and had scans number of years down the road. So they showed that on average, actually the liver volume mostly stabilized for many patients down to this new lower level. They were able to show that certainly many patients actually continued to some decline, but about half of them did show slight growth. And so that is something that accounts for some of that symptomatology. And I certainly defer to Dr. Torres' expertise in terms of any other further dissection of that data. Dr. Hogan then followed up with this paper really to show that from a quality of life perspective and a symptom perspective, these patients, for the vast majority of them, improved significantly from these operations. You can see how their symptoms for the most part dropped. There were some patients, obviously, 1 or 2 that didn't improve significantly, but many of them had significant reductions in their symptoms and in significant improvements in their quality of life. And then this is probably my favorite figure from that paper that looks at some of those various domains which they asked polycystic patients about and how their liver disease affects them, whether that's a lack of appetite, early satiety, which is early feeling full afterwards, reflux, nausea, pressure, pain, shortness of breath, fatigue, anxiety about the future. You can say the thing that probably improved the least was the patient's anxiety about the disease. And then obviously other components of really patients' overall life. So how do we approach these patients? Well, really the approach that I was taught by Dr. Nagorny and what I've tried to bring back to Toronto on the patients that I've shared with Dr. Pei and others is really to make sure that we identify and preserve as much of the healthy liver as we can. and to try and be as aggressive as possible with the cystic disease, especially when there's areas of the liver that are dominated by cysts with very little parenchyma. So you can see the top panel there is a patient that would be ideal for resection and fenestration. Almost the entire right side of their liver is replaced by cyst, but the left side of the liver, and I'll just show you for those not familiar, this is all of this healthy liver over here is something that we want to preserve. In these types of patients, these are really those Schnelldorfer D patients that, there's really not a lot of easy liver to preserve. Those are very difficult patients, and certainly we've shared some of those patients, and unfortunately we're not able to offer them anything that productive. So we'll go back to our case. So this is our lady again, just a reminder, she's kind of 48. She's been dealing with this for many years. And again, this was kind of her disease. And again, much like those cases that I showed you, she had a lot of disease on the right-hand side of the liver. She had some dominant disease in the middle of her liver, but the left side of the liver had a lot less disease. What we were able to do is actually remove the vast majority of the right side of her liver and debulk a lot of the left side disease, particularly take out the cystic disease in the middle. This was her afterwards. And one of the things that I noticed, sure, the cysts are still there. They're much smaller, but also you also see significant growth. I perceived, and we've tried to do this volumetrically, growth of the normal liver. So I actually think that her liver is actually probably healthier than it was before the operation, that she had nice growth of the disease there. So listen, I want to thank you all for inviting me. It's a tremendous honor. It's a tremendous honor to be here with Dr. Pei and Dr. Torres and be able to share some of my interest in this disease. Thank you so much.
Thank you very much, Sean.